the pharmacodynamic and the pharmacokinetic properties of misoprostol. So I will directly proceed to misoprostol uses in second trimester. She's already discussed, it's a prostaglandin E1 analog. It remains stable at room temperature. It is helpful in cervical rattling and induction of labor. Can be used orally, vaginally, sublingually and buccally. So I would like to bring forth this side. So sublingual, the absorption happens in very rapidly in 30 minutes. And orally also the absorption happens very rapidly in 30 minutes. The duration of action is around 6 hours. But vaginally the absorption is gradual. It takes around 70 to 80 minutes, and the mode of it stays for a longer duration of action also. So this point I will be bringing forward in my next slide. So we just remember that vaginal, it takes it's a gradual absorption, and the action also stays for a longer duration of time. For 12 to 24 weeks of period of gestation, in India, our MISI and Miso combi packs are only allowed till 9 weeks of gestation, that is still 63 days. For 9 to 12 weeks of gestation, Government of India says that the line clearly mentioned in the MPP Act is that surgical abortion should be offered to the patients. And beyond that, from 13 weeks onwards, MISI and Miso is not allowed according to the DGCI. So these guidelines are from WHO 2022 and SIGO 2023. We all use these, and this is more acceptable also. So for abortions between 12 to 24 weeks, the recommended dose is Misoprostol 200 milligram orally, followed by 1 to 2 days later of 400 micrograms of misoprostol given every 3 hourly. Here we are giving it buccally, sublingually or vaginally. The minimum time interval between MISI and Miso should be at least 24 hours. And for the maximum doses of Miso that we can give to this patient, maximum usually 5 doses is what is recommended. And the success rate is to the tune of 95%. The other regimen, which is, so with this, the abortion rate which happens within 24 hours is almost in all studies, they said 90 to 95%. And the induction to abortion interval time, that means after completing our course of MISI and Miso, usually the patients will abort in a time of 6 to 8 hours. Coming on to the second regimen, when misoprostol is not available, in those cases we can also just offer these patients 400 micrograms of misoprostol repeated every 3 hourly. But again, the success rate goes down because misoprostol helps. So this is a set of studies. So here the abortion rate, it comes down to around 80%. It is not 95%. And the induction to the abortion interval, it increases and it comes around 15 to 20 hours. So the preferred regimen is MISI plus Miso. Coming on to next 25 to 28 weeks of gestation. So all of us know as the gestation advances, the sensitivity towards misoprostol goes on increasing. The receptors keep on building up and we require lesser and lesser doses of misoprostol. So for this, misoprostol remains same, 200 milligram orally, followed by a day later of misoprostol 200 micrograms. For 12 to 24 weeks of gestation, we were giving 400 Miso. Now we are going to be giving 200 Miso every 3 hours. Further, beyond 28 weeks of gestation, misoprostol is 100 micrograms repeated every 3 hourly. MISI remains the same. Now, this is what I was talking about, ladies who have not had any previous cesarean section. They have just had normal vaginal birth. Now, let us talk about ladies who have a previous scar. So, if there is a previous only single scar, that means she's had a previous one cesarean, or if she's had a previous myomectomy, then for those ladies, the risk of uterine rupture is less than 0.3%. But however, if there are more than 2 scars, if she's had previous 2 cesareans or she's had 1 cesarean and 1 myomectomy, then the risk increases. So ladies which have only previous 1 scar, for them, the regimen changes. For 13 to 20 weeks of gestation, we are giving 400 Miso and it is 6 hourly. So herein comes the route of per vaginal, because we are giving per vaginal, it will have a gradual onset of action, it will stay longer, and that is why the repeat dose is also increased to 6 hourly. For 21 to 26 weeks of gestation, the dose is decreased to 200 repeated every 6 hours. The success rate remains 70 to 80% and there was no scar rupture reported. The other regimens which can be tried in these ladies are intracervical Foley's catheter and oxytocin infusion, or even now we've come up, even these studies are very promising, in which Misoprostol was given, only Misoprostol was given 200 milligrams twice daily, that is 8 hourly for 48 hours. So there was this study, and I think we all very commonly follow it also, that we give low dose vaginal Misoprostol in patients who have scars, 100 micrograms every 6 hourly, and we insert a Foley's catheter and fill it with 30 ml of saline beyond the internal os, tape it to the thigh with a little bit of traction, and this also gives us very good results. So this was for all those patients which had induced abortions. For missed abortions, for incomplete abortions, they are not calculated according to the period of gestation, that is from the last menstrual period. For these ladies who have a missed abortion or who have incomplete abortion, it is calculated according to the size of the uterus. In this, again, the dose remains the same, Misoprostol 200 milligrams, followed by Misoprostol of 800 micrograms. In case of fetal demise, again, the dose gradually decreases. Till 24 weeks of gestation, we are giving 400 micrograms every 3 hourly. From 25 to 27 weeks of gestation, we are giving 200 micrograms. And for more than 28 weeks of gestation, we are giving 50 to 100 micrograms. The other use of Misoprostol, apart from patients who have induced abortion or missed abortion or incomplete abortion, is some patients may opt for a surgical abortion, that is between 9 to 13 weeks of gestation. In that, we can use Misoprostol 400 micrograms prior to the procedure for pre-procedure dilatation. And lastly, if in the case of medical abortion, in these patients also, if they have a lot of post-abortal hemorrhage, then again 1000 micrograms of Misoprostol can be given orally, buccally, or can be placed for rectal. So, but all these are just guidelines which have been picked up from WHO 2022 and FIGO 2023. Each case needs to be individualized. A Paris lady will require a definitely lower dose. So, keeping in mind the parity of the lady, the cervical findings, how is the contractions progressing? I'm not saying that you continue giving 400 micrograms every 3 hours. If you've gone into labor, a lesser dose should be given. So, medical methods for second trimester induced abortion have considerably improved. It is advisable that second trimester terminations take place in a healthcare facility where blood transfusion and emergency surgery are available. The combined regimen significantly reduces the dose of Misoprostol and the time taken to abort. Very few side effects like nausea, vomiting, diarrhea, fever, and shivering are reported. Individualization is the key. Keeping into account the parity of the lady, the cervical findings, previous scar on the uterus, and the healthcare facility we work with. So this is the chart which Dr. Kirti had also shown. I think we can keep it handy in our OPD practices, the recommended regimen given by FIGO in 2023. Thank you. Together we learn.